distinguished guests, colleagues, and friends, thanks again for the opportunity to give this presentation at the 4th NIL Symposium. I'm here today to present some findings on Suaahara using our process evaluation data to look at the effect that the program had on exposure, knowledge, and practices, and also on equity and narrowing gaps between disadvantaged households and non-disadvantaged households in intervention areas. This is a brief outline of the presentation. I'll start with a background of the Suaahara program, because you will hear several presentations about Suaahara, so it's a good idea if we have some basic understanding of what the intervention actually did. Then explain the aims and the methods of the study, some of our results, and some conclusions that can be drawn from the results, as well as some conclusions that maybe should not be drawn. This is an overview of Suaahara that many in the room are likely familiar with. This is Suaahara 1, which took place from 2011 to 2016, a USAID-funded multi-sectoral nutrition intervention that aimed to improve the nutritional status of women and children under 2 years of age. In other words, those in the 1,000-day period between conception to a child's second birthday. The actual primary outcome was to reduce stunting from around 38% to 32% in intervention areas, doing so via 4 intermediate results or 4 primary pathways. The first of which was to improve health, hygiene, and nutrition behaviors at the household level, to increase the availability and use of quality health services, to increase the access and consumption of nutritious and diverse foods, and also to strengthen coordination among nutrition actors, both in the government sector and among other actors in Nepal. This is a map to explain where the Suaahara intervention took place, and it's color-coded because the actual implementation took place in a staged approach. Those districts in dark blue were the initial 20 intervention districts. Districts in light blue were the 5 additional districts added slightly later. And most recently, the districts in gray were added, so 16 districts, totaling 41 districts and aiming to reach 625,000 households with a core package of young child, maternal, child health interventions, WASH interventions, primarily through social behavior change communications approaches. I should also say that there were additional interventions such as homestead food production and nutrition governance, which did not cover all of the households, but covered select disadvantaged group areas, either by community or by households, identified by the government's criteria for ranking VDCs by their proportion of DAG population. This is the implementation timeline, and if you look at this, I really want to make 2 points. The first is that designing and implementing multi-sectoral programs is challenging. And it's challenging more than we anticipate, and it takes a long time to roll out and to reach what we actually call implementation, meaning household level reach of the program. The baseline survey for the program was done in 2012 in the rainy season, and actual implementation, the earliest it started was about 7 months later with some of the core package components in some areas. And then you had more interventions happening along the way with an inline plan for later. So this shows you that it took around 23 months, and that's the exposure time period that's relevant for the data that you will see today, because it's only after slightly less than 2 years of program implementation that we saw the results that we see. So what is a process evaluation, and why did we do this? It's a midline study to basically check in and see if the program is reaching coverage that it intends to reach. So in other words, have households been reached by the program, and is there a change in knowledge and particular practices? And the primary research question that we had is, to what extent, rather than yes or no, are Suaahara interventions actually reaching the target audiences? And we looked at a variety of different Suaahara interventions, such as the Banchanama program, frontline worker interactions, and so on. This was a quantitative household survey. The data collection was done by Valley Research Group, who is in the room, and the ethical approval was obtained from the Nepal Health Research Council. For the sampling, we had both intervention and comparison areas. We covered 8 districts and ultimately 480 households. This map is to show you a little bit more about the study sampling and why. The blue and red districts are actually the districts that were selected for the baseline survey in 2012. The blue districts are the intervention districts, and they were the phase 1 intervention districts selected so that at inline they would have the maximum length of exposure to see impact. The red are the matched comparison districts, so it's a quasi-experimental study in which a matched design was used to identify similar areas and similar households to the Suaahara intervention areas. So there were 8 matched district pairs at baseline. 4 of the 8 pairs were chosen for the process evaluation study. And you can see those 8 process evaluation districts with a yellow star. The same VDCs and wards that were used at baseline, which were chosen based on PPS techniques and a random sampling method, were also chosen for the process evaluation. Where the study differs is at the household level sampling. We did not look for a random sampling because this was not intended as an impact evaluation. It was not a follow-up to baseline. It was a process evaluation study intended to look at 2 years post the program implementation. Do we see uptake and utilization of program activities? And you can see here the 4 types of households chosen rather than the random sampling. A disadvantaged pregnant woman, a non-disadvantaged pregnant woman, a disadvantaged mother of a child under 2, and a non-disadvantaged mother of a child under 2. And the reason for this is that with Suaahara's explicit objective of reaching disadvantaged households, we were trying to see if that actually happened with the program and what was going on in the disadvantaged communities in the intervention areas. So these are the study aims and methods. It's slightly a repeat of what you saw previously, but basically we're trying to assess Suaahara's progress in increasing exposure to information and services and how this may have translated into knowledge and practice changes among the pregnant women and the mothers of children under 2 in rural Nepal. We also wanted to explore the narrowing of gaps between the disadvantaged and the non-disadvantaged households. To do so, it was an entirely quantitative study. We used descriptive statistics between the 2 different areas, and we adjusted our regression analysis for a variety of child, maternal, and household level confounders, as well as the clustering. And for the equity analysis, we used an interaction term to explore this in our regression analysis. These are some of the results, and I don't expect you to be able to see this. This is just to present the sample characteristics and to highlight the fact that you see in the comparison areas and the intervention areas very similar populations. So this is important to note because we need to know if the only difference in the areas was the actual program or if there were other demographic characteristics, socioeconomic characteristics that might explain the changes you see. There were 2 exceptions to this that were significantly different between the 2 areas. The first is age at pregnancy, which was slightly higher, about 8 months later in the intervention areas. Perhaps not surprising because perhaps it's not background, perhaps it's related to the family planning interventions that were a part of Suaahara. The other one that is surprising is the highly statistically significant finding of the larger number of households that have improved roof materials, permanent roof materials in Suaahara areas than non-Suaahara areas, perhaps indicating some socioeconomic difference, although it's the only SES indicator that was different in the sample characteristics. I will not present all of our findings because we have a lot, so you will see today a sampling of the findings. And for all of the slides throughout the rest of the presentation, the blue bars indicate Suaahara areas and the gray bars indicate comparison areas. This slide is just to indicate that the exposure to frontline workers in areas that Suaahara was aiming for actually are higher in the Suaahara areas. So for example, something like a home visited ever by an FCHV. Obviously, in Nepal, the FCHVs existed prior to Suaahara, so it's not surprising that that was equal in the comparison areas and the intervention areas. However, something like whether the household saw an FCHV outside of a home visit or a mother's group, which are the standard ways they would see one, is much higher in the Suaahara areas. The stars indicate statistical significance. For simplicity's sake, I'll say the more stars, the more likely that this finding is not due to chance. This slide is a host of maternal and child nutrition and health, WASH, and family planning messages that the Suaahara program was promoting for these 2 years that it was intervening. And as you can see, for all of the different messages, the exposure level is much higher in the Suaahara areas than in the comparison areas, and it's statistically significant. And as one example, I can tell you that the message about feeding animal source foods only after 6 months of age, you had exposure in the Suaahara areas. 87% of mothers said that they have heard this message, whereas only 32% in comparison areas had heard this message. So now we'll look at knowledge. You see that knowledge is also higher in Suaahara areas than comparison areas for most outcomes, such as the need for 45 iron and folic acid tablets, the need for 180 days of iron and folic acid tablets during pregnancy, and these findings are statistically significant. But not all differences that you see were actually statistically significant, such as the number of checkups that are needed for antenatal care. This is more knowledge findings, but these are related to child health and nutrition. So, for example, the consequences of child malnutrition, you had many more mothers reporting what those consequences might be, cognitive development, physical development, et cetera, than you had in the comparison areas. The one that we find really interesting is the exclusive breastfeeding definition, because this was asked as an open-ended question, asking the mother to give a definition of what exclusive breastfeeding means. And we only considered it correct if they said, introduction of no foods other than breast milk, including water. And so what you have here is a very precise definition that was able to give an open recall by 68% of women in Suaahara areas and only 16% of women in the comparison areas. Moving on, it does seem that exposure is higher in Suaahara areas, which is what one would expect. It seems that knowledge levels are also higher, but we're often curious what's happening with practices. So as you can see here, these are some of the maternal health and nutrition findings related to practices. And for many of these practices, the level is slightly higher in Suaahara areas, and for some practices, that difference is statistically significant. So for example, whether the FCHV was consulted as a source of antenatal care is higher in the Suaahara areas, and also in things like eating more than usual during pregnancy, which was a major focus of the Suaahara program. You have more than 3/4 of women in Suaahara areas reporting that this is what happened, whereas you have not even 1/3 in the comparison areas reporting this. These are some more practice findings on going now to child health and nutrition. And what you can see here, again, is consistent that for most cases, although not all, the prevalence of the practice is slightly higher in the Suaahara area than in the comparison area. And some of these differences are statistically significant. So again, with exclusive breastfeeding, we have much higher rates of that happening in the Suaahara areas than in the comparison areas. Also for colostrum and for the vitamin A, being received within 6 weeks of delivery and in the last distribution. So now to the equity analysis, which is a little bit more complex to understand. What we did here was we looked at the difference between the DAG community and the non-DAG community in the comparison area, and the difference between the DAG community and the non-DAG community in the Suaahara area. And we used the interaction term in the regression model and checked to see whether the interaction term was statistically significant. And what you see here are the same exposure variables that you saw previously, just divided by intervention and comparison area. And we see that for most of the exposure variables that we are measuring, you do have a significant finding of a difference. In other words, the gap between the disadvantaged community and the non-disadvantaged community was narrower than in the Suaahara areas than the gap between the disadvantaged and the non-disadvantaged communities in the comparison area. And we're testing to see whether that difference in gaps is statistically significant. So we've done the same thing for knowledge, and what you see here is an example of the findings in which, once again, it was significant. So the age at which to introduce water, the age at which to introduce milk, and also, very interestingly, child illness. And so one of the main findings is that in Suaahara areas, the knowledge was even higher among the disadvantaged groups than the non-disadvantaged groups about some of the very difficult to move indicators globally, such as feeding during child illness. I also want to point out on this slide that there are only a few knowledge indicators mentioned, and that's because there's a slew of other knowledge indicators in which the interaction term was not significant, and those have been omitted for simplicity's sake. The same is true for practices. So you can see here that we have several instances, such as eating more than usual during pregnancy or using the FCHV as a source of antenatal care, which I mentioned previously. The narrower gap, or actually because of the negative sign, it means it was higher in the DAG areas than the non-DAG area, is actually showing that the equity for these specific practice indicators was significantly better in Suaahara areas than non-Suaahara areas. So in conclusion, what can we say about all of this? The results show that effective scale can be achieved, and that reach can happen even in complex multi-sectoral interventions, and that at the same time you can address equity. In other words, there doesn't have to be a compromise between addressing equity and coverage at scale. You can also see that after only 2 years of program exposure, that there are large differences between exposure, knowledge, and practices between the comparison and the intervention groups. You can also note that progress can be made on very difficult to move child nutrition indicators, such as appropriate sick child feeding, even when you're working on more than nutrition and you're including things like WASH and family planning. However, some caveats. More work needs to be done. While this is encouraging, we did not see movement on all indicators, and some indicators that we saw movement on, we didn't see 100% coverage even in Suaahara areas or 100% knowledge. And that indicates that both in Suaahara and non-Suaahara areas, there is work remaining. Finally, I would like to point out that investments in research and rigorous evaluations need to be invested in not only a financial sense, but in an academic and in an intellectual sense. This is cross-sectional data, and I would just make a point now to say that while the results are very interesting and indicative, we do not have causal findings. You cannot indicate 100% for sure that Suaahara is what generated this, because it is a data set from one point in time, and you might see this throughout the conference as well, and you should be careful about what conclusions you draw from it, and it should encourage all of us to remember that nationally level representative data sets, such as the DHS, cannot serve as program impact evaluations, and one simple cross-sectional study, while informative and interesting, also cannot prove what a study accomplished. And therefore, with my researcher hat on, I encourage us to all think about the way that programs and research can be combined, and to not use many of the phrases I heard on the opening panel, such as good evidence, rigorous evidence, evidence-based programs, unless we truly mean what we say. Thank you.